Hello people, in this video let us look at this terminology xerophthalmia. So we are reading this in what? In ophthalmology, right? So xerophthalmia, right? Xerophthalmia. Zero is what? It's dry. So ophthalmia, something to do with the eye. So dry eye. So it stands for xerophthalmia stands for dry eye. But actually xerophthalmia is a word used for all the problems which are caused in the eye because of vitamin A deficiency. Okay. So, did you understand the terminology, guys? Vitamin A deficiency, ocular symptoms, ocular manifestations of vitamin A deficiency is coming under this heading xerophthalmia. Okay, it's an ophthalmology topic. So, what is xerophthalmia? It is to cover all the ocular manifestations of vitamin A deficiency. Right, not only structural changes, okay, not only structural changes they are saying, but even if there are biophysical disorders of the retinal rods and cones function. So even if there is functions problem, even if there is structure problem, whatever it is, because of vitamin A if it is caused, they are calling it, bringing it under xerophthalmia. So what is xerophthalmia? Xerophthalmia is if vitamin A deficiency is there is less vitamin A, and if there is any structural problem in the eye, right, or if there is any functional problem in the eye, like the retinal rods and cones have some functional problems, they all come under xerophthalmia. So this terminology is clear for us now. Now, why does xerophthalmia occur? You already know the etiology, vitamin A deficiency. Now, why does vitamin A deficiency occur? Either you didn't eat enough vitamin A, okay, you didn't get enough vitamin A, maybe you did not get it along with your vaccination, they would have given you a lot of vitamin A doses, maybe you didn't get that, okay, then or you're taking all the vitamin A unfortunately and it's not getting absorbed, right, absorption is defective, so that also can happen. So deficiency in the dietary deficiency or defective absorption, etc., etc. It has long been recognized that vitamin A deficiency does not occur as an isolated problem. So it is not just an isolated problem. A lot of manifestations will be there in the body, like protein energy malnutrition, infections. Wow, this just got scary. So it's not just this man's eye that is affected now. What and all is affected? It has long been recognized that vitamin A deficiency does not occur as an isolated problem, not just isolated problem, but is almost invariably accompanied by PEM, that is protein energy malnutrition and infection. So this guy is not only having some specific symptoms, he's also having some protein energy malnutrition and he's having infections. Okay. Let's move on. So basically whenever they ask you preventable blindness is one of these, okay, vitamin A, preventable blindness, vitamin A deficiency, right, and trachoma, remember these two, okay, there are a lot of examples, but for corneal blindness, they are blaming vitamin A deficiency and trachoma, so they are saying these are preventable blindness, right guys? If beforehand this person has taken enough vitamin A, then definitely he won't get vitamin A deficiency. When it comes to trachoma, what do they say? Trachoma, they will do a lot of hygiene and lot of things, right? So that is how trachoma, they try to avoid mass antibiotic also they give, isn't it? That is what we studied in trachoma. Let's go back and visit that trachoma thing, okay? But just remember here, preventable blindness, easily you can prevent, okay, by attacking the causative factor. Causative factor only you can attack, okay, take a lot of vitamin A. But remember, vitamin A is not all that safe also, it has vitamin A toxicosis also. So anyways, vitamin A you need, okay. Nothing is good, bad in more. Anyways, now let us come to the WHO classification of xerophthalmia. Xerophthalmia, basically, why does it ocular manifestations occur? That nobody explained, right? Okay, fine. Night blindness occurs. So what and all is happening? Night blindness, see this image, night blindness is occurring. So this is the earliest thing, night blindness is occurring, right? Then they are talking about some conjunctival xerosis. Conjunctiva gets dry. This is conjunctiva, bulbar conjunctiva getting dry. Then Bitot spots are there. See here on the conjunctiva, Bitot spots. So all these are some manifestations. Then you have corneal manifestations. Under the WHO classification, we are continuing. Then you have corneal problems. Corneal problems will be cornea xerosis. You can see a dry cornea here, right? A dry cornea. Then corneal ulceration. less than 1/3 of corneal surface. If it is there, then it is this X3A, Xerophthalmia 3A, and 3B is if it is more than 1/3 of the corneal surface. Here you can see that more than 1/3 of the corneal surface, that becomes the 3B. Just remember, in this whatever you're seeing are cornea, corneal xerosis, cornea ulceration, and lastly corneal scar, right? This is corneal scar as XS, xerophthalmia scar, corneal scar, okay? Then lastly, in WHO classification, you have xerophthalmic fundus. So did you understand the classification? WHO classification of xerophthalmia. WHO classification of xerophthalmia, you saw first it will start with night blindness and then some conjunctival xerosis and then Bitot spots, right? After that we saw cornea signs like cornea, dry cornea, then cornea ulceration less than 1/3, cornea ulceration more than 1/3, then cornea, one more was there, what was that? I forgot, wait. Cornea scar, corneal scar, okay. Then you had, lastly they are talking about fundus, xerophthalmic fundus. So finally it reached the fundus, okay. So let us look at all the details. But first of all, do you understand why vitamin A deficiency is affecting the eye? So you would have heard of all this Wald's visual cycle and all that, right? Wait. Vitamin A, what and all it does? You know all that. Do you remember this Wald's visual cycle, visual cascade and all these things? So this guy George Wald, he explained this rhodopsin. So rhodopsin is there what? In the rods, right? In the eyes, in the cones, in the retina you have the cones, right? Sorry, in the rods. In the rods you have rhodopsin, right? So that is 11-cis retinal. All this so you can understand, right? This is Wald's visual cycle. Where is vitamin A in this? That mystery is answered here. The synthesis of the visual pigment requires vitamin A. So vitamin A is present in the cytoplasm of the rods, right? In the pigment layer of retina. And in the pigment layer of retina, you have all trans retinol. So basically you are understanding, right? When there is excess retinal, it's converted back to vitamin A. So this is where that vitamin A secret comes. So you have seen that vitamin A not only has ocular, it helps ocular, it also helps growth, right? So there can be growth retardation if there is vitamin A deficiency. It helps in reproduction, skin, mainly skin, right? If you have less vitamin A, it will lead to dry skin, okay? So you should have enough vitamin A to have some nice moist skin, okay? So mainly let's rhodopsin. So let's just summarize here. Rhodopsin, correctly, right? Then skin, you need it for some skin also. You need growth, reproduction, everything you need, okay? But anyways, here we are concerned about these things. Growth, reproduction, okay? So basically this rhodopsin is helping in what? In seeing in the night, right? In the less light, right? Dim light. So basically that is called as scotopic vision. So night vision is a function of rods, rhodopsin. Guys, focus, please. So basically if there is a vitamin A, you can see nicely in the night also. But if vitamin, not as good as animals, of course, but if there is vitamin A deficiency, you will have decreased night vision. Why? Because the rhodopsin is not proper in the rods, right? You know where the retina is, all that we should explain or what? So where is the retina, guys? Innermost, here you have the retina. The retina's layers are explained here. Here you have the rods and cones. Here we are talking about what? The rods. Because rods will help you see in the dim light. Black, white, all that. Black, white, all that it will help you see. Cones for color. C for C. Cones for color. R is for what? Black and white. Okay. So this is vitamin A. That is why we are having all these problems now. If vitamin A is less, then what to do? Earliest symptom is night blindness. It's also called as nyctalopia, right? It's not written here. Nyctalopia, right? Nyctalopia. Basically it is ZN, xerosis, night blindness. Let's remember like that, or some other meaning is there for it. ZN. Sorry, XN. Why am I saying Z? XN. So XN is night blindness, nyctalopia. Night, that is scotopic vision, is a function of rods. Yes, we know this, guys. Night scotopic vision is a function of what? Rods, yes. So rhodopsin, Wald's visual cycle, all that we explained. So this is the earliest symptom. Earliest symptom. Okay. This is the earliest symptom of xerophthalmia in children. Okay, that is also very specific. Okay. Then conjunctival xerosis, we are moving to this one, 1. After night blindness is coming 1. In that 1A and 1B you have, both are something to do with the conjunctiva. Here you can see conjunctival xerosis. There is dryness of what? Of the conjunctiva. So they seem to be indicating the bulbar conjunctiva here. Right? This is the bulbar conjunctiva. So there should be dryness. That will become X1A. Right? Conjunctival xerosis, dryness. Mucin deficiency, dry eye. So basically it consists of one or more patches of dry, lusterless, non-wettable conjunctiva which has been well described as emerging like sand banks at receding tide. What the hell is this? They are explaining it as emerging like sand banks at receding tide. This is how the dry patches are, right? So when the child ceases to cry, that time these are described as emerging like sandbanks at receding eye. Let me read this sentence completely. Please listen. It consists, what is this? This X1A conjunctival xerosis consists of one or more patches of dry, lusterless, non-wettable conjunctiva, okay, which has been described as this thing when the child ceases to cry. Okay. These patches almost always involve the interpalpebral area of the temporal quadrants and often the nasal quadrants as well. In more advanced cases, the entire bulbar conjunctiva may be affected. Typical xerosis may be associated with conjunctival thickening, wrinkling and pigmentation. So what and all can be there? Thickening, wrinkling, pigmentation. Okay. So initially it will be patches, then mostly on the temporal side, then even the nasal side will get affected and entire thing will get affected. Now let us move on to X1B Bitot Spots. So Bitot Spots, guys, Bitot Spots are shown here in this image. Look at this, Bitot Spots. This will be X1B, Bitot Spots, B for Bitot Spots. It is an extension of the xerotic process. It's an extension of this X1A. So basically, how are these spots? They are raised, silvery white, foamy, triangular patch of keratinized epithelium. So here you can see it, right? It's pretty clear. Foamy. Remember that word, foamy. F-O-A-M-Y. Foamy. Okay. White, silvery white. Okay. Triangular patch of keratinized epithelium situated on the bulbar conjunctiva in the interpalpebral area. It is usually bilateral and temporal. So you can see here it is on the temporal side, right? And they are saying it will be bilateral. So it should be there in the other eye also. Usually it is bilateral. It is not that frequent nasally. So obviously it is more frequent to the temporal side and not to the nose of this guy, not towards the nose. Okay. So we are done with the first 3 in the WHO classification, guys. So basically night blindness, conjunctival xerosis of 2 things, X1A, X1B. Okay, conjunctiva over. Next what will we go to? We will have to check about the cornea and read all about the cornea. Then we have to understand what changes are there in the fundus. We'll come to all this. Before that, before we go to corneal changes and fundus changes, let us look at other terminologies here. Okay. So what are we discussing today? Xerophthalmia. Okay. So what is Keratomalacia? So basically you need to learn this word. Keratomalacia refer to corneal necrosis. Okay. So that is in the WHO classification. When we are coming to cornea, there they will explain this word, corneal malacia. So we will come to that. Cornea necrosis and all they are saying, ulceration, necrosis, etc. Then what happens in these people? You are seeing that night blindness will be there, conjunctiva is affected, cornea is affected, fundal changes are there. But as a symptom, dark adaptation, delayed dark adaptation will be there. Okay. Dark adaptation means what? They are outside, let us say in the balcony, and they are looking at the sky and everything, and they come inside the house and suddenly it's a little dim, right? The light. So they can't adapt suddenly. So that is dark adaptation, delayed dark adaptation. Isn't that what dark adaptation is? So dark adaptation. So when a person moves from brightly lit area to a dark area, the retina becomes more sensitive to light. Yeah, that only. Okay. So actually this dark adaptation can happen even in retinitis pigmentosa. It can happen even in vitamin A deficiency. Okay. Then moving on. Keratomalacia, this word we saw. Then Moving on guys, night blindness, Nyctalopia. Basically Nyctalopia can be caused by vitamin A deficiency and a lot of other conditions, okay. Not night blindness means don't say vitamin A deficiency. It's one of the cause. Retinitis pigmentosa, then there can be other degenerations, congenital night blindness, pathological myopia, cataract, vitamin A deficiency they're explaining here again or what? Okay. Some Aguchi's disease. So lot of reasons are there for night blindness. Don't jump to vitamin A deficiency only. Xerophthalmia, what is the treatment? Basically, you'll have to give as a prophylaxis. It's a preventable blindness, so you'll have to give a lot of vitamin A supplements to babies, to lactating mothers also. And if there is deficiency, you will have to give some supplements again to treat this deficiency as a curative. So what are the sources of vitamin A? A lot of sources are there. Look at them. Carrots, papaya. Is there a papaya there? Yeah. Some green leafy vegetables, eggs. They have shown milk here. And they seem to be showing some supplements. Okay. The thing with vitamin A, there can be adverse ocular effects also. Like we told you, right? Vitamin A in excess also, hypervitaminosis also is not good. Okay. So there are some side effects of vitamin A also. Papilloedema, retinal hemorrhage, loss of eyebrow and eyelash, nystagmus, diplopia, blurring of vision. Okay. So a lot of issues are there with vitamin A also. Right, taking excess. So guys, where did we leave off? We left it off at the WHO classification. We finished the conjunctival. Now we have to move to cornea science, right? We'll move to cornea science. Then we will look at the fundus changes also. Okay, then we will go to the treatment, right? Treatment in detail we'll have to look at. Okay, so now let us continue with this corneal xerosis. What do you say? Take a deep breath and let's start with corneal xerosis. This is an important topic, guys, the xerophthalmia for exam. So let's look at it. Corneal xerosis. The earliest change in the cornea is punctate keratopathy. So this is the one they're talking about. Corneal xerosis, dryness of the cornea. You can clearly see here that cornea, the luster is not there, right, of the cornea. Okay, so corneal xerosis is the earliest change. The earliest change in the cornea is punctate keratopathy, which begins in the lower nasal quadrant. So they're talking about the lower nasal quadrant. Is this the one? This is nasal definitely. In the lower nasal they are saying. So punctate keratopathy followed by haziness or, so it should be in the cornea, right? So it should be here. What do you say? Lower nasal quadrant. Followed by haziness or granular pebbly dryness. What is this? Granular pebbly dryness. Involved cornea lacks luster. That definitely we can see here. Cornea is not having luster at all. So that was about corneal xerosis. Now let's move on to the next one here. Corneal ulceration keratomalacia. This is the word we saw there. Keratomalacia. Corneal necrosis. That's what they said. Corneal ulceration, corneal necrosis, less than 1/3 of the corneal surface. That becomes X3A. 3A is talking about that 1/3 thing. Remember. So here you have the cornea xerophthalmia stage X3A. Why? Because there is a corneal ulcer keratomalacia involving less than 1/3 of the corneal surface. Pretty clear here. Stromal defects. Okay, they're talking, and let us look at the other one also. Hold on. Together we will see. This one is involving more than 1/3 of the cornea. So this will be 3B, right? X3B. 3A, 3B. X3A, X3B. Stromal defects occur in late stage due to colliquative necrosis and takes several forms. They're talking about colliquative necrosis here. The more specific about the keratomalacia, the necrosis, colliquative necrosis. Okay. The type of necrosis. Small ulcers occur peripherally. Yes, we can see the ulcer is peripheral, right? Not in the center. It's in the periphery. The ulcer occurs peripherally. Right? They are characteristically circular with steep margins. They are characteristically circular. Yeah, they look circular with steep margins and are sharply demarcated. Yes, they are sharply demarcated. We can clearly see that they are sharply demarcated. Ulcers, large ulcers and areas of necrosis may extend centrally or involve the entire cornea. Yeah, they are extending centrally and they can involve entire cornea. If appropriate therapy is instituted immediately, stromal defects involving less than 1/3 of the corneal surface, X3A, usually heal, leaving some useful vision. So at this stage till here, X3A seems like they can save the vision, right? However, large stromal defects like X3B, they result in blindness. So, as soon as you see any dot on the cornea, that means it is still recoverable. Go soon to the doctor, ophthalmologist. Now let's move on, guys. 3B is also over. Then we are moving on to XS, corneal scar. XS means where you should think there is no clue here which place they are talking about. It is corneal scar. Okay, this is because of xerophthalmia again. Corneal scar, healing of stromal defects result in corneal scars. So what that stroma and all was affected, now the stromas are healing and this will result in corneal scars of different densities and sizes which may or may not cover the pupillary area. Where is pupil? It may or may not cover the pupillary area. Okay. So a detailed history is required to ascertain the cause of corneal opacity. So if there is some corneal opacity, you will have to take a detailed history. Okay. So we are done with the cornea. What and all are there in cornea? 2. That is 2 is corneal xerosis. 3A, 3B ulcer size, corneal ulcer. Then X is corneal scar. So first whatever we saw was night blindness, conjunctival xerosis and Bitot spots, which is again on the conjunctiva. X1A, X1B, then we have X2, X3A, X3B, and there is no X4 here, it is XS, corneal scar. Lastly, it is XF, xerophthalmic fundus. Let us look at the fundus now, okay. Now we are going into the pupil and using an ophthalmoscope and checking the fundus, okay. Xerophthalmic fundus is characterized by typical seed-like raised whitish lesions scattered uniformly. Okay, are you able to see? At the level of the optic disc, they are saying. Some white, yes, I can see. Whitish lesions scattered uniformly. Yes, it looks like that. Seed-like raised. Okay, yeah, it seems like that. Okay. So we have finished the WHO classification of xerophthalmia. Good. So now what else is left, guys? So what and all we have seen so far, we saw what this terminology is, what the definition is, the etiology. We saw it as a preventable blindness, vitamin A, rhodopsin, skin growth, reproduction. We saw conjunctival problems, we saw corneal problems, we saw fundus issues. Now we have to go to, what do we have to go to now? Treatment, right? Treatment. So we'll look at this treatment, okay. So treatment means, obviously you will have 2 types here. Prophylaxis and to treat deficiency. Let us look at this treatment. Basically, treatment when you're saying dryness and all that, you can correct it with artificial tears, etc. But when it comes to vitamin A therapy, let's look at that. Local ocular therapy, what will you give? Local ocular therapy, let's put it here only, to treat the deficiency. Local ocular therapy will have all that artificial tears, right? That is hydroxypropyl methyl cellulose or hypromellose, right? This you can all give if there is xerosis, conjunctival xerosis. In the stage of Keratomalacia, that is little necrosis, ulcer, etc., you will have to give treatment for bacterial corneal ulcer, okay? So, for dryness, you will give artificial tears, right? And for Keratomalacia, you will give treatment of bacterial corneal ulcer. Should be some antibiotics, etc. You will have to look at that part of the treatment. Artificial tears like hydroxypropyl methyl cellulose, hypromellose, all these basically for what? For conjunctival xerosis. Okay. Guys, these are all nothing to do with vitamin A. Now we will come to the actual vitamin A doses. Okay, you need to remember them. So where did we put the demarcation of reversible and kind of irreversible? At 3 here, right? So let's write here. Till here, it can be treated or reversed or something. Some word like that. Exact word we don't know. You have to look at the textbook. Reversed. Okay. Now where are we? Treatment, right? Okay. Vitamin A therapy. Now we will go to the exact vitamin A therapy. Okay, how much vitamin A should be given. So to all stages, you will have to give the vitamin A, right? Because they are all caused by vitamin A deficiency. But they are telling till X3B you can give. Then what happens? Till X3B they have mentioned, but they didn't mention XS and XF, that is corneal scar and fundus changes, they didn't mention. To treat deficiency, they have mentioned here, oral administration is recommended. So they are suggesting oral vitamin A, okay. Oral vitamin A is suggested. If they are not tolerating, then intramuscular injection. So basically any person who is greater than 1 year, guys, any person greater than 1 year, you will give orally 2 lakh international units. Otherwise, intramuscularly, if you are giving 1 lakh international unit is enough. Give on that day. Next day you can repeat, and then after 4 weeks again. Okay. Now if they are giving it to a person who is less than 1 year, let's see less than 1 year what happens. Okay. So less than 1 year, basically children of any age who weighed less than 8 kg. So if it is less than 1 year, or children of age, sorry, not age, of any age less than 8 kg. Okay. For them, what will you give? Half the dose. Half the dose. Okay. Then women of reproductive age. Obviously these people will require more, right? So here you will have who are not having night blindness, who are having night blindness. Okay, so there are a lot of stages here. They should be treated with 10,000 international units of vitamin A orally for 2 weeks. So basically if they are XN, X1A, X1B, then they will give what? 10,000 international units of vitamin A orally. 10,000 international units of vitamin A orally, obviously oral only, this is oral column. This is nothing but one sugar coated tablet for 2 weeks. One sugar coated tablet for 2 weeks. If these women have corneal xerophthalmia, that will be what? Corneal xerophthalmia will be what? Let's take this here, guys. If they have corneal xerophthalmia, that is X2, is it? Corneal xerophthalmia and anything else I'm thinking, because anything to do with the cornea, administration of full dosage schedule as per 1 year age, right? Above 1 year age, same thing. So they're saying this one you will give. Okay. If they are of reproductive age, whether they are pregnant or not doesn't matter. Okay. And they have deficiency. Okay. So all these cases are if they have deficiency, guys. So note here, if you go with deficiency, then you will be given this 2 lakh international units orally. That will be the most likely. Okay. Then if children go with deficiency, they'll get half that same dose. And here women of reproductive age with this severe deficiency, they are giving 2 lakh international units only. But what I'm not understanding, if they are reproductive age and if they are having initial vitamin deficiency, they are giving it slowly over 2 weeks. Why is this? Okay. And then one more thing they are talking about here is you address the ocular things, you address the vitamin also, then you should address one more thing, that if there is anything else, right, any other disorder, like we spoke of so many disorders that can be there, right, because of vitamin A deficiency, like you will have to handle all those. What is happening? Like here, if they are telling treat other conditions, okay, such as PEM, etc. What did we say? PEM and one more thing we said, no? In that person will be there. Infections, etc. Right? So this is what is the treatment if they have deficiency. So this deficiency part we saw. Now let us look at the prophylaxis part. Okay. Let's look at the prophylaxis here. Xerophthalmia. OPHTHL. Okay, ophthalmia. Think about lactating mother. Whereas lactating mother, 20,000 international units orally once at delivery and during the next 2 months. So basically this will raise the concentration of vitamin A in breast milk and therefore it will protect the breastfed infant. So vitamin A is going from mother's milk to the child. Breast milk has vitamin A. Okay. So they will give it to mother also, vitamin A. That is why lactating mothers here they are talking about. So one more thing they are telling here, if there is an infant less than 6 months and if it is not being breastfed, then you will have to give the baby itself. If it is not being breastfed, then the infant less than 6 months will have to receive 50,000 international units. Okay. So less than that 1 lakh. So 50,000 international units for less than 6 months if they are not being breastfed only. Okay. Then what else? What they are saying here is there is something called as Child Survival and Safe Motherhood. CSSM, Child Survival and Safe Motherhood. In there they are saying along with the measles vaccine in 9 months, give 1 lakh international dose, 1 lakh international units at 9 months. Guys, please remember this, 1 lakh international units at 9 months along with the measles vaccine. The second dose will be at 18 months when the child is taking the DPT booster, the first DPT booster when it is taking. DPT booster 1, that time at 18 months give this, and then at 2 years give the third dose, that is same thing, 2 lakh international units, because now the child is 2 years. Did this make any sense? Wait, let us write it neatly again. At 9 months along with measles vaccine, because it is less than 1 year, you will give 1 lakh international units. Then at 18 months along with the DPT booster, you will give 2 lakh international units, and then at 2 years, that is 24 months, you will give the third dose, that is again 2 lakh international units, because you have to give for anybody greater than 1 year, you have to give 2 lakh international units orally. So here this is the key, greater than 1 year oral 2 lakh international units. Okay, this is what, if you remember, most of it you will understand. Right? Okay. So where are we? So we finished this. This was short-term approach. Now there is still some more. Medium-term approach and long-term approach. So much is there in this. Medium-term approach and long-term approach. Medium-term approach includes food fortification. Food fortification with vitamin A. And what is long-term approach? It should be ultimate aim. It implies promotion of adequate intake of vitamin A rich fruits like green leafy vegetables, papaya, drumsticks, nutritional health education, etc., etc. So hopefully you understood all this. Long term is like food rich in vitamin A. Food fortification is like you'll add micronutrients to food. So just revise this one short term approach, CSSM. Child Survival and Safe Motherhood, isn't it? Child Survival and Safe Motherhood. So basically in this one you remember, at 9 months along with measles vaccine 1 lakh international units, at 18 months along with DPT booster 1 2 lakh international units, 2 years 2 lakh international units. Okay. So before 6 months doesn't it need vitamin A? Yes, before 6 months it will get via breast milk. Okay. Before 6 months, what will happen then? Should get vitamin A via breast milk. Okay. So this covers this very important topic, xerophthalmia. So hope you have understood. Let's take a quick recap and finish off this video. What do you say, guys? Let's take a quick recap. Xerophthalmia, it stands for actually dry eye. It is actually ocular symptoms, ocular manifestations of vitamin A deficiency. These can be structural changes or functional changes. So this happens when there is deficiency of dietary deficiency of vitamin A or defective absorption of vitamin A. It is a preventable blindness. Vitamin A helps in Wald's visual cycle, rhodopsin. It's there in this pigment, scotopic vision, skin. It helps in the main, if it's not there, it becomes dry, the skin becomes dry. It also helps in growth, reproduction. So the classification of xerophthalmia is the XN. XN is night blindness. Nyctalopia is the earliest. Then you have the conjunctival xerosis, Bitot spots. Then you have corneal things, Corneal Xerosis. You have the corneal ulceration keratomalacia, less than 1/3 of the corneal surface. Then you have corneal ulceration keratomalacia, that is X3B, that is affecting greater than 1/3 of the corneal surface. Corneal scar excess, that is excess. Then after that you have excess, the xerophthalmic fundus you have. Then guys, what is keratomalacia? Corneal necrosis. Dark adaptation can be delayed because of vitamin A deficiency or because of retinitis pigmentosa. Nyctalopia or night blindness can be caused by many reasons other than vitamin A deficiency. Treatment, if there is deficiency, you will give ocular therapy. Conjunctival xerosis, you will give artificial tears. You will also treat any bacterial corneal problems. Then you will usually prefer vitamin A oral. Okay, and then if there are any other conditions in that person like protein energy, malnutrition, infections, you'll have to treat that also. When it comes to the actual treatment of the deficiency, remember orally you will give 2 lakh international units to any person who is greater than 1 year. That day you will give, then the next day, and then after 4 weeks you will give 1 more. Okay. Then for everybody else, children, etc., half the dose, etc. Now coming to prophylaxis, they have the CSSM. Before 6 months, anyways it will get via the lactating mother, it will get the vitamin A. And then 9 months along with measles vaccine, 1 lakh international units. 18 months along with DPT booster 1, you will give 2 lakh international units. And at the second year, they'll give 2 lakh international units. This is the short term. Medium term is food fortification. Long term is food rich in vitamin A. Okay, vitamin A also has some adverse ocular effects, which is also bad, like papilledema, retinal hemorrhage, loss of eyebrows, eyelashes, nystagmus, diplopia. Interesting. Okay. So just close this video by learning what exactly the sources of vitamin A are, natural sources. Okay, that's all for now. Bye bye.